All right, good morning, everyone, and welcome to the first Semel Grand Rounds of the 2020-2021 academic year. We have a wonderful series of talks on the calendar for this year. If you're interested to see what's coming next, you can view the schedule by going to the website semelgrandrounds.com. A few reminders before we get started. To claim CME credit for viewing this presentation, please check your email after the presentation ends. Also, if you have a question for the speaker, you can use the Q&A button to submit it at any time, either during the presentation or during the Q&A session. And now, Dr. Kalafanos will introduce this morning's speaker.
Hello, our speaker today is the CEO of the Wellesley Institute and an international expert on the social causes of mental illness and suicide, as well as an expert on the development of effective and equitable health systems. He's also Director of Health Equity at the Center for Addiction and Mental Health and Professor in the Department of Psychiatry at the University of Toronto. As a policy advisor, clinician, and academic psychiatrist with over 200 papers and 5 books, he's worked across a broad spectrum to improve population health and health services for over 2 decades. He's currently a member of the National Advisory Council on Poverty and previously was an advisor to Ontario's Basic Income Pilot Project. He sits on the board of United Way Toronto and the Ontario Hospitals Association. In addition to his academic, policy, and clinical work, he's a columnist for The Guardian, Times Online, and Toronto Star, and a past BBC radio presenter. I know his work on the social causes of schizophrenia, and it's very informative and inspiring. Recommend everybody look up his work. We are honored to be hosting him today for the Semel Grand Rounds. His talk today is entitled, "Why Are There Racial Disparities in Mental Health in Canada?" Please join me in welcoming Dr. Kwame McKenzie.
Thank you, and thank you very much for that amazing introduction. I'm now hoping to share screens, and I hope that's worked very well. My name is Dr. Kwame McKenzie. I'm a psychiatrist. As Dr. Kalafanos said, I spent a lot of my time working in the social causes of schizophrenia, and from that, I've moved into being still a practicing psychiatrist. Still, I work as in policy in psychiatric institutions, but I also now do a lot of work in policy in government, and part of that is how I've ended up with this sort of presentation at this sort of time, which I think works very well for the zeitgeist of the current situation that we find ourselves in North America. After George Floyd. Any of you who've been to the UK will have heard the phrase, if you've been into London and you've been on the London tube, you'll have seen, which is the underground, you'll have heard them saying, mind the gap. And everybody's heard this, it says, mind the gap between the train and the platform. But not many people understand why there's a gap. It's quite simple, actually. There's a gap between the train and the platform, as you can see from this slide, because some of the stations are curved. And if you have a train which comes into a curved platforms, some parts of the train carriage are closer to the platform than others, and there's a gap. And why am I talking about this gap? Well, because 300 people each year on the London Underground fall between the gap in the train and the platform. And the gap has been there since the start of the London Underground in 1863. And every year, 300 people, 400 people, many more people fall through it. But nobody has ever found a solution for this. And part of the reason for that is because everybody knows why the gap exists, but nobody puts any focus on why the gap persists. And so part of what you need to do in order to work out how to fill in the gap is to understand why the gap persists. And the gap that I'm going to be talking about today, and I'm hoping that it will lead to some reflections and to some discussion about what's happening in the United States, is the gap between some of the things we say and what actually happens in mental health. And so it's the gap of the difference between what's possible and the disparities that we see in mental health for particular populations. And I'm going to be talking about the African and Caribbean population of Canada. So Canada, 37 million people population, with a comment that diversity is our strength. That's one of the mottos of Canada. We pride ourselves as being nice people, as you know, and it's civility and fairness with a socialized health care, free at the point of access, and very welcoming to immigrants. And that's a picture of our Prime Minister, Justin Trudeau, at a Black Lives Matter rally where he took the knee. And that's the picture that we get of Canada. When you talk to the Black population, you get a slightly different picture of Canada. 1.2 million people, so 3.5% of the population, and really very diverse population. Includes people who've been in Canada since the 1600s, includes economic migrants, refugees from the Caribbean, people from Africa, and people who've come from the USA North. Our biggest province, Ontario, has the largest number of people of African and Caribbean heritage, but most provinces have a significant Black population. And despite the fact that we've got socialized healthcare free at the point of access, despite the fact that we say that diversity is our strength, mental health problems are considered one of the top priorities in the Black populations, and our Black population do not think enough has been done for their mental health. And so the question that we're going to be talking about today is, what can be done about that? What interventions can actually improve the mental health of the Black population in Canada? So the aims of this Grand Rounds: understand the evidence of racial disparities in mental health in Canada, understand the theory that came from Canada of anti-Black racism, and understand the types of initiatives which could actually decrease disparities in mental health for the Black population in Canada. And then, you know, maybe in the question and answer, we'll use that to reflect on what it means for the USA. So let's start with the evidence, and I'll present four academic papers. The first is the Black Experience Project. And the Black Experience Project is a project of snowballing project of 1,500 Black people in the Greater Toronto area. And there were the extensive interviews of 1 to 2 hours with each of these people. So it's this huge project, huge data set that is available online through the Environics Institute. And one of the questions they asked was about stress. And this is a simple graph looking at the percentage of people who said they had little stress, some stress, or a lot of stress, comparing the white population in blue, what they call the visible minority population, which is generally exactly what it sounds like, people who are non-white minorities. And then just comparing that to a subsection of that population, which is the Black population. And you'll see that the Black population are less likely to have little stress, less likely to have some stress, and more likely to say that they suffer from a lot of stress. And that's similar when you actually do self-rated mental health. And the important thing about self-rated mental health is, though it's a very straightforward question about people saying whether their mental health is excellent or very good, good or fair to poor, when people do cross-cultural analyses and validations, this actually does correlate very well with the GHQ and the pH, the pH9 and things like that. And again, we've got the white population in blue, the visible minority population in red, and then the black population in green. And you can see they're less likely, the black population, to see that their mental health is excellent or very good. We're talking about 65%. More likely to say it's either good or it's fair. And so this correlates pretty well to common mental disorders. And so we've got higher rates of a risk of common mental disorders in the black population in the Greater Toronto area, which is where the majority of the black population in Canada live. Another paper is about psychosis. And we looked at first contact incidence of psychosis for immigrants and refugees in Ontario, and that's Anderson et al. And this was a study that looked at all people 14 to 40 aged in Ontario, because we were trying to get first onset psychosis, most of which happens before the age of 40. And we used physician billings and hospitalizations, and we have an algorithm that we use that's a validated algorithm in physician billings and hospitalizations to identify people with psychosis, which is based on hospital diagnosis, and if they haven't been hospitalized, 2 diagnoses in primary care and 2 different physicians prescribing antipsychotic medication. And we link that to the immigration database. We have a database of everybody who has been come into Canada since the 1980s, and that has been linked to physician billings and hospitalizations to give us a robust data set of millions of people. And one of the things that was interesting about this is that we were able to show, and these are odds ratios compared to the general population, people of Caribbean origin with a 60% increase of risk of schizophrenia, South Asian population, 10% increase. But one of the interesting things from our perspective was to look at the East Asian population and those who are immigrants from Northern Europe, who actually have a much lower risk of schizophrenia than other groups. And one of the reasons that's interesting to us is because the difference between that increased incidence and that decreased incidence for immigrant groups gives us a target for prevention. What is happening in the Caribbean group that's not happening in the East Asian group, that's not happening in Northern European migrants, that is leading to the increased risk of schizophrenia. And so that's a very interesting piece of work for us, because in the UK, obviously, we've seen much higher risks of schizophrenia in the Caribbean population, but their immigration is much less, is more indiscriminate than Canadian immigration, which is based on a point system and which aims to try to make sure that people who come into Canada are healthy. When we've also looked at, so we've looked and we've seen increased incidence of common mental disorders and stress. We've seen increased incidence for the Caribbean population, not so much for the African population on psychosis, but we've also been interested to see whether they get care. And so not only the incidence, but also service use. And so this is a study which we did where we tried to map pathways to care. And we wanted to map pathways to first episode psychosis care for different immigrant groups. And we were interested in people of African origin, people of Caribbean origin, people of European origin, and people who were North American migrants to Ontario. And we used a SCID to diagnose psychosis, And then we also looked at the treatment of the duration of untreated psychosis using the SOS. And then we used the encounter form, which had previously been used in World Health Organization studies to look at pathways to care. And what we saw in our studies was that both the Black African and the Black Caribbean group were more likely to have their first contact in the emergency department. So the first contact for psychosis was in the emergency department, compared to about half as many people in the white European and the North American. And so this is a percentage of people whose first contact within the emergency department: Black African 27%, Caribbean 33%, white European 15%, white North American 16%. We're also interested to see whether the first contact in the prison justice system was more likely. And we found for the Black African population, 21% their first contact was through the prison justice system. The Black Caribbean, actually a lower percentage coming through the prison justice system. And then white European, 12%, and then the white North American, 20%. And this figure, where the Black Caribbean group were less likely to go through the prison justice system than expected, was one of the things which stuck out to us. We also were interested in criminal involvement in the GP, and also GP involvement. And again, we found that, and this would make sense obviously, that the Black Caribbean group and the Black African group less likely to have a GP involved in their pathway to care, which you'd expect because they are more likely to end up in the emergency department than being referred to psychiatric services. And then the white European group and white North American group had a family doctor involved in their pathway to care more often. The criminal justice involvement during their pathways to care mirrored their first contact routes through the prison justice system. And the last study was about spending. So we know that there's a higher risk of common mental disorders. We know that there's a higher risk of psychosis in the Caribbean group and possibly in the African group as well. And we know that there are difficulties in pathways to care for some of these groups. But psychosis is by far the most expensive and hospitalization, the most expensive things that we do in the Canadian system. So if we were actually meeting the needs of the Caribbean population, we would expect higher per capita spending in the Caribbean population because of the treatment of psychosis and hospitalizations. And what we found was the East Asian population, which had a lower rate of psychosis, actually had a lower spend per capita. So these are dollars. And so the per capita spend of $120 is 120 times the size of the population over each year. And so it comes up to a reasonable amount of money. And we found that the South Asian population, though they had a 10% increase in the risk of schizophrenia, were not using services. The Caribbean population, 60% increase in services, but still they were using service. They had a less of a spend on this population than you have on the non-immigrant population, which have a lower risk of psychosis. So it looked like not only did we have higher rates of depression and anxiety and stress, and higher rates of and higher rates of psychosis with some problems in pathways to care. But actually our care provision and our spending was lower than would be expected for the Caribbean population, despite increased need. So that's the data that we have on what's happening in the Black population with regards to mental health. There's more data, but I think you get the picture. And then the question is, how does that pertain to these ideas that are outside in the rest of society around racism? Now, if we were going to think about racism and health, the usual theories that we'd see of the impact of racism and health would be a diagram a bit like this. This is a review that was done by Pascoe and Richman in 2009 of about 400 papers, which was looking at the links between perceived discrimination and mental and physical health. And this was a sort of statistical paper which was trying to look at what evidence there was to support particular pathways that were hypothesized by past research. And these hypotheses was that perceived racism is directly related to mental and physical health, as in the experience of perceived discrimination. And that's pathway A, which was proved by the literature. Another pathway was perceived discrimination leads to a heightened stress response, and that leads to increased rates of mental health problems. And again, they were able to analyze this pathway and show this, found it much more difficult to actually demonstrate that the heightened stress response was linked to mental health. Similarly, this perceived discrimination leading to different health behaviors, time discounting, increased substance misuse, increased alcohol intake, and reckless behavior. That was shown by the literature, but it was more difficult to demonstrate that those health behaviors were the reason for increased rates of mental and physical health. But this is the sort of model that people have been producing to try and explain how racism and perceived discrimination might lead to mental and physical health problems. The Canadian Medical Association did a wonderful analysis back in 2005, and basically did a literature review and meta-analysis trying to answer the question, what makes Canadians sick? And they're trying to say, well, what percentage of your risk of illness and your difficulty in getting better from illness is linked to your biology, your environment, your access to healthcare, and your life? And they demonstrated that 50% of your risk of illness was actually linked to the social determinants of health: income, early childhood development, education, gender, race, Aboriginal status, housing, and community engagement. 10% was your environment, air quality and civic infrastructure. 25% was access to healthcare, the healthcare system, and wait times. And only about 15% were linked to your biology and genetics. And so this is part of the Canadian Medical Association's ideas of what the determinants of health are. And if we believe that, and we believe that the majority of your risk of illness is linked to your life and your environment and your access to healthcare, or 85%, then it behoves us to think about what's happening in the African and Caribbean population in Canada, if we are now going to say that we're going to think through the causes of illness. And I could show you charts all day long which seem to show that the African and Caribbean, the Black population in Canada, isn't doing as well as it could. Black women are actually doing very well with regards to post-secondary education. And this solid yellow line is the percentage of Black women with a post-secondary education in the population. And the solid blue line is the percentage of women in the rest of the population with a post-secondary education. And so they're tracking pretty similarly. The yellow dotted line is Black men and post-secondary education. And you can see that this is tracking downwards. It was higher than other men, but over time, the rest of the population is overtaking and the Black population is falling behind. So this is one of the things that's happening, and what's actually happening is this is the second and the third generation who are not doing as well as the first generation. And so back in 2001, these figures were dominated by first generation immigrants, and now these are being dominated by their children and their children's children, and they're falling behind. In fact, if you look at the rate of poverty in Canada, the rates of poverty for the first generation of people of African and Caribbean origin is lower than it is for the second generation or the third generation. And so this is poverty is increasing in the Black population in Canada, but for no other populations in Canada. Certainly that is happening in the macro, but in the individual, thwarted aspirations are becoming more common. And so what this piece of work does is it just shows, and these are all data from the federal government, is on the one side, it shows expectations and aspirations. So the Black population in yellow, the rest of the population in blue, and the question is, would you like to obtain a university degree? And the vast majority, 95% of the Black population had the aspiration, this is of people between 15 and 25, they had the aspiration and expectation of getting a university degree, but only 60% of them actually think they will obtain that degree. So when you look at the rest of the population, this aspiration and what they think is going to happen in practice are actually very close to each other. But when you look at the Black population, what people want and what they think will happen are vastly different, 35% difference. And you can imagine that that is a nidus for significant thwarted aspirations and frustrations in the population if people would like a degree, but they think it's not going to happen for them. Another way of measuring where a group is to look at thriving. And one of the things we've been doing in the Wellesley Institute, where I work, is we developed an index of thriving. It's easy to look at poverty levels, and we wanted to say, well, let's actually look at how much people need to live a healthy life, and we'll call that the level of thriving. So what income do you need to live in a way that is actually healthy? And what you've got here is poverty levels below the low income measure after tax, people who sit between the low income measure after tax and to the thriving, and people who have enough money to thrive. And we know that there is a straight line between the levels of mental health problems and health problems, with people who are thriving having longer lives and less morbidity than people who are between poverty and thriving than people who are living in poverty. And what you have here is the Black population in blue, the white population of Canada, of Ontario this is, in red, and then the rest of the population in green. And you can see that the Black population, I said Ontario, it's actually the Greater Toronto area, which is half of Ontario's population, more likely to live in poverty, more likely to live between the poverty line and thriving, and by far the least likely group to be thriving. And so that predicts that there are going to be frustrations, that predicts that there's going to be financial insecurity, that predicts that there'll be poorer housing and poorer jobs, and that all of those things through the social determinants of health are linked to poorer health. It's not surprising that a professor at Ryerson University in Toronto coined the phrase anti-Black racism. And the idea was that there was multiple inequities because of structural racism, which produces a toxic social environment, which produces worse outcomes for Black people. And the lack of acknowledgement of the importance of implicit, direct, and systemic bias, and the lack of action to decrease racism is the basis for the persistence of those disparities. So what can we do to decrease disparities for the Black populations of Canada? And all of these things are stolen from other places. I'm basing this on this good artist copy, great artist steal, which actually was said by Stravinsky first, then T.S. Eliot, then Picasso, then Steve Jobs. So all of them steal from each other. And usually when we're thinking about culturally competent systems, and this is from the Mental Health Commission of Canada, we think that we need culturally competent staff, so actions to improve cultural safety and the competence of health system staff. We need culturally competent interventions, so the interventions that we have to work equitably for different groups. And then we need culturally competent systems, action on the social determinants of health, and access to care to make sure that people actually get to the culturally competent interventions given by the culturally competent staff. And we've been working on this. So this is the Immigrant and Refugee Mental Health Project, which is a free online 2 to 3 month training on improving the care of immigrant and refugee populations paid by Immigration, Refugee and Citizenship Canada. A huge project, been running for 3 or 4 years, and thousands of people, I think 5, 6 or 7,000 people have taken this training. We've developed interventions. So we've developed, this is just one type of adapted cognitive behavioral therapy that we've developed, which we've shown improve outcomes. This is actually for the French and Creole speaking people of Caribbean origin. We've got one for African speaking, another for Spanish speaking. And so we have culturally adapted interventions that go with the development of our culturally competent staff. And then we've been working at a system level at the Centre for Addictions and Mental Health, producing niche services for the Black population. We have 2 community health clinics in Toronto specifically for the Black population. We have community groups like the Black Health Alliance. The University of Toronto has developed an entrance system just for Black medical students. And then the Public Health Agency of Canada has developed a whole research effort around building new tools to improve the health service response for people of Caribbean origin. African and Black Caribbean origin. And so all of those levels of cultural competence are things that we've been working on. But the question is that going to decrease disparities? And this is the Broad Street Pump. And I'm showing you the Broad Street Pump because the Broad Street Pump was a place where a chap called John Snow, and you can see his name on the pub there, who was a public health physician, was working. He was working downtown in London in the 18th century, and he found that there was an outbreak of cholera. And he was one of the first people to use geographical mapping to look at the causes and to try and find causes of the outbreak. And he found that there was downtown in Soho, in London, there was the big outbreak there, just around where this pump was. And then there was a smaller outbreak in North London. And he did some interviews of the families in North London to try and work out what their relationship was to the people who were in Soho. And he found that the people in North London liked the taste of the water that came from this pump so much that they were sending their servants down to get this water. And he hypothesized that there was something in the water, because this was before anybody had thought of bacteria or viruses. He thought there may be something in the water that was causing this problem. And so in an attack in public health vandalism, he went and took off and cut off the handle to the pump. And having done that, he stopped the whole of the outbreak. But that's not what he started. From that came the idea that there was something in the water, then came germ theory, and then came all of the big changes that we've had in antibiotics and vaccination and all of these other things. John Snow, from his vandalism, probably saved millions and millions of lives in the end, and he's, the biggest accolade you can have in the UK for saving huge amounts of lives, and because he never got a Nobel Prize, but in the UK if you can get a pub named after you, that's about the biggest accolade that you can have. So why am I telling you this? Well, at the time of John Snow, the big disparities in longevity and illness between rich and poor were due to infections. And because of John Snow and germ theory and antibiotics and immunization and sanitation and clean water, the impact of infections on health disparities and longevity between rich and poor decreased significantly. But the gap in life expectancy between rich and poor did not decrease as significantly as you'd expect. And now those disparities between rich and poor are not due to infections so much. They're due to chronic diseases like diabetes. They're due to survival from cancer, and now they're due to COVID. And so some people are saying, well, what exactly is happening here? And they're saying that actually there are fundamental causes of disparities, and then there are mechanisms, and then there are health outcomes. And some of the things that we think are causes, such as infections, are actually mechanisms by which fundamental causes, such as racism or access to knowledge, power, and money, lead to differences in health outcomes. And if you get rid of one mechanism, then often what actually happens is that another mechanism expands. So if you get rid of infections as a cause of health disparities, then chronic disease takes over because the fundamental cause has not gone away. And because of this newer theories that many social determinants are mechanisms, not causes, people think that effective equity interventions should be targeting the fundamental causes of disparities, not just the mechanisms. And some people believe that structural racism is a fundamental cause, and that if you actually want to deal with the disparities in health between the Black population and the white population, or the disparities in mental health between Canada's Black population and the rest of the population, you have to start thinking about what you're going to do about racism. You're going to have to think about what you're going to do about access to power, money, and self-determination, all of which are fundamental causes which are working through the system to cause difference. And so this is some of the thinking that is now happening in Canada. Heritage Canada have developed an anti-racism strategy. There's a push for anti-racism to be considered a public health issue, and for there to be legislation which has been used in other countries, like in the UK, that means that public services have to promote race relations. They also have to have equitable services and be able to prove it. The Ontario itself, at a provincial level, have an anti-racism directorate, which mean that the police and also others, such as school and also children's aid societies, have to collect race-based data. And Toronto has started launching some anti-racism strategies, and one of them is a Black Mental Health Day. And before taking questions, I'll just show you the ad campaign from the City of Toronto about mental health and Black mental health. So the first one reads, and these were put up all across Toronto, bus shelters and various other places. And this is the City of Toronto speaking for its Black populations. And just two more. And the last one. So we started off with this question about why there are disparities in health and what is going on in Canada, and what this means for, what this means for the US. Well, there are higher rates of stress, there are higher rates of risk of common mental disorders, there are higher rates of psychosis, there's lower rates, or there's difficulties in accessing services, and differences in the amount we spend on services. The theory that has come up is because this is the social determinants of health, and that work on the social determinants of health may improve outcomes better than just work on the services. Now, don't get me wrong, I believe that all services need to be equitable, and work to produce equitable services is important. But there's also this question of fundamental social causes, and the fact that these fundamental social causes are driving inequities. And so the question that comes back to us as clinicians, and one of the reasons why I work both in clinical practice, in developing clinical services, and in policies, is what's our position and what should we be doing to help those who want to advocate for significant social change. Because it may be that one of the ways we get into better outcomes for the people we care about is to support them in their advocacy in areas that are way outside our normal comfort zone. Thank you.
Thank you very much, Dr. McKenzie, for that broad-ranging and really stimulating talk. As questions come in, so please, this is the time from the audience where you guys have a chance to write questions in, and I'll be posing them to Dr. McKenzie. I just wanted to make a couple comments and maybe kick things off with a question, just to reflect on that talk. I really appreciate your kind of foregrounding anti-Black racism as really a global phenomenon. Canada, of course, has a lot of interesting similarities, interesting differences with the US, both histories of settler colonies and histories of slavery, but distinct histories of slavery, of course, and distinct immigration patterns. One big distinction that jumped out of your data was the rates of contact with criminal justice for folks in mental health crisis. And as I'm sure you know, in the US, for Black and brown populations, it's much higher, much more likely to be in contact with criminal justice. So one thing it would be interesting to hear you about is reflecting on that difference. Is that because Canada has a more robust health system, or is it just a totally different criminal justice system? You should be hearing your reflection on that. Also, in thinking about addressing the root causes, I really appreciate your call for us to address social determinants as the root fundamental causes of a lot of common illness, mental illness, and otherwise. And as we think about those, and you sort of foregrounded kind of Black Mental Health Day as sort of a public education campaign, but so much of racism and racial inequality is structural, and also structures economic inequalities, right? So like the history of redlining in the United States, which, right, sort of compounds inequities in housing and education by spatializing race and wealth. And so what's the role of really looking at interventions to address that level of economic inequality that is racialized? And I know there's internationally, there's sort of a movement for universal social protections. The United States recently rediscovered social democracy and the benefit of having a public sector. Maybe sometimes it is good to have public sector services, we're learning. And I know you've worked on basic income. So what's the role of those kinds of interventions in mitigating some of these inequalities and some of these outcomes?
Okay, so start with the first question, and I'll try and be brief in the answers so you can get more questions in, is the fact that people don't end up coming through mental health services doesn't mean that the prison justice system aren't involved. I think if you go to lots of prisons in Canada, you'll find a higher proportion of people of African and Caribbean origin, 2 or 3 times the rate of other groups, and you'll find a high proportion of people with mental health problems in prison rather than in the system. So I think there is probably something going on there where people are still ending up in the prison justice system. They just don't end up in the hospitals as much. And if they do end up in the hospitals, sometimes it's in forensic hospitals without a diagnosis of psychosis. and they don't get to first episode services, which is what we were trying to look at. I doubt there is that much difference between the US and Canada in this regard, though Canadians would love to think there is. And with regards to this idea of social protection, yeah, I worked on the basic income study, and the basic income study in Ontario was one of the biggest there'd ever been. And it was very clear from the basic income study that you could decrease mental health problems and mental health service use by a basic income. We've gone a bit further in the Wellesley Institute and talked about a thriving income. And when we think of a thriving income, we are not thinking that every job needs to pay 25, $30 an hour. We're saying that between the salaries that people get and the social protection they get, it should be a resource that is sufficient for them to thrive. And so some of it can be income, some of it can be housing benefits, some of it can be healthcare, some of it can be dental, some of it could be debt forgiveness. If, say, for instance, they'd gone to school and they had debt, they could be forgiven that. And some of it could be increased pensions so that there's less that people have to save for. And so I think there are loads of ways of doing it. And interestingly, I had one of the biggest firms in Canada with me yesterday saying, how can we partner with the government in order to solidify our recovery? We want to take a part. Yeah, we know it's not just government or industry. We've got to be working together. What should we be doing and what should government be doing? And I think in the future, we'll be thinking about portfolio benefit systems, a bit like people have portfolio careers, where there's a bit from government, there's a bit from industry, there's a bit from third sector, but they make up to a whole. And as you move, you can move one way and have it mainly from industry, or another way and have it from government, but everybody gets at least that baseline so that people aren't in poverty.
Great, thanks. So one of the questions been posed from the audience, have you found that Canada has a population that objects to the country's efforts towards anti-racism? And if so, what have some of the responses been? How has the official response been, and what are there lessons for the United States kind of to take away from that? Okay,
so yes, there are people definitely in Canada who believe that this idea of anti-racism is ridiculous. Yes, there are people who think that there is no racism in Canada and people are just complaining. In Canada, that is the minority. And so it's relatively easy for somebody like Trudeau to take the knee. He'll get some pushback, but the majority of Canadians will say, no, something's got to get done here. And so at the moment, any government here can ride the tide of, as long as it's pulling everybody along, of saying, well, we've got our Indigenous population, we've got our Black population, and we need to do something to help them. So, I mean, and it's interesting that if you ask the Black population, in fact, if you ask in Toronto, the whole population of Toronto, they will tell you that 84% of them will say the police do a good job. And 75% of them will say, but they don't look after Black people properly. And it's that sort of nuance where they say, no, actually, right, there's loads of good things about the police, but there's a problem we've got to sort out, which is where a lot of governments are going. I think leadership is really important because in the end, a lot of people some people have sort of very firm views on one side, some people have very firm views on the other side, but most people are in the middle and can be convinced. And if there's good leadership with a good plan, they'll give it the better benefit of the doubt as long as the country's going in the right direction. And at the moment, Canada's sort of going in the right direction. So people are willing to give it the benefit of the doubt. We'll see what happens during the economic downturn.
There's quite a few questions that kind of want to dig into some of this data that you presented. So one about this generational difference in Black immigrants, given that the first generation seemed like they had more favorable mental health outcomes and were a bit more successful along economic lines as well. How do you kind of reconcile that? Is that an issue of racism? Is it a issue of something else? And then a related question was, how do you reconcile this finding of Black women being more educated with this overall sort of phenomenon of structural racism? So kind of two related questions about the kind of microphysics of race.
Yeah, so I mean, most definitely sort of fabulous questions and difficult questions. I'll tell you why. I've shown you the whole of Canada, right? If I were to show you, take out Ontario and Quebec, the Black population looks pretty good. But when you look at Quebec and Ontario, the big populous places with the big cities, something's going wrong in our cities and in those places. And something is going wrong for Black men in those cities and in those places. And so it's not Canada as a whole. There is something going on in our major cities so Montreal and Toronto, that is an interaction between place and people. And so it looks like it's environmental and social. It looks like it's the social environment in those places, not the people, because elsewhere in Canada, there are thriving Black populations, not totally, but more thriving Black populations. So yeah, it's something to do with the way we're running our big cities that seems to be the issue. And
what are the leading hypotheses for what those things are?
I think that one of the things that's happening in Toronto is a widening gap between rich and poor. And when you have widening gaps between rich and poor, and specifically you have widening gaps between your racialized population and your non-racialized population, people try and find ways of catching up. And one way of catching up is to try and make quick money, and that gives you a whole gang culture. Another way is to not get into your educational system because you don't think it's going to get you anywhere because it didn't get your parents anywhere. And so that's an issue. But also the actual pathways to that resource. When I say that resource is in jobs and good jobs, is much more difficult in those populations. Unfortunately, Toronto is segregated. Yeah. Downtown is becoming whiter and the outskirts are becoming darker. And more and more of the wealth is concentrating downtown, and that is leaving people behind. And so downtown public schools are really quite good, but schools on the outskirts are really not. Access to jobs downtown Toronto, I mean, Amazon were looking here, Google wanted to build a smart city here. You can have a wonderful life in downtown Toronto, but it's very different on the outskirts. And those sorts of frustrations of income inequality are the same for anywhere where you find income inequality. Here it's been racialized, and we're producing subpopulations that are moving in the wrong direction. So it is an interaction between macroeconomic and macro-political changes and immigration and race, which is producing a relatively toxic environment, and then things cycle. So our downtown Toronto policies don't meet the needs of our racialized populations. And just in COVID, say for instance, we've got rates of infection downtown Toronto in our predominantly white neighborhoods that are 20 per 100,000. And we've got rates of infection in our predominantly black populations, which are 500 per 100,000. Yeah. So we've got these huge disparities just sitting there. And that is a mirror of where we're going. And we have to sort of look at all of these things in order to try and equalize.
Well, thank you so much, Dr. McKenzie. Really, really appreciate you taking the time out to give us this talk. And yeah, just wanted to say to everyone online, thank you for joining, and we'll see you again next week for Grand Rounds.
Yeah, thank you very much. Different sort of Grand Rounds, but hopefully stimulating, and thank you very much for inviting me. I didn't realize it was the first of this season, so thank you very much.
Thank you.
Thank you.